Again, welcome and thank you for joining us today. This is our webinar series called Sight and Sound Bites. It's brought to you by the Eye and Ear Foundation. My name is Craig Smith and I'm Director of Development and Community Initiatives for the Foundation. This bi-weekly webinar series highlights research in the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh School of Medicine. This research is only possible thanks to generous philanthropic support, so we want to thank everybody who has supported our mission in the past. I want to go over a few quick housekeeping items for today. For these webinars, we do disable the chat function, so you will not be able to chat. However, the Q&A function is open and ready and available the entire presentation. So if you have questions for our presenter, please submit them at any point, and then after his presentation, we will go ahead and get to all those questions. We do ask that you refrain from asking any very personal questions that may not be relevant to the broader audience. However, we would like to answer those for you all the same. So if you'd like to ask a question that is fairly specific to your own case, please feel free to email it to me at craig@eyeandear.org, and I'd be happy to get that over to our presenter. We've also enabled captioning for this program, so feel free to use subtitles as you follow along. We are recording this webinar, and as always, we'll be adding it to our website and our YouTube channel, and also emailing everybody who attends a copy of the recording. And additionally, all of you who are attending today will be added to our mailing list so you can receive periodic updates on the research initiatives taking place within the departments through things like blogs, newsletters, and future webinar invitations. So now to get to today's presentation, the title of today's presentation is Waking Up to Change, the New Era of Sleep Apnea Treatments. I'm joined by Dr. Thomas Kaffenberger. Dr. Kaffenberger is an assistant professor in the Department of Otolaryngology Head Neck Surgery here at the University of Pittsburgh School of Medicine. He's a member of the American Academy of Otolaryngology-Head Neck Surgery, the American Head Neck Society, the International Surgical Sleep Society, and the American Academy of Sleep Medicine. Dr. Kaffenberger is passionate about improving the outcomes of sleep surgery for snoring and obstructive sleep apnea through research and clinical trials, and providing personalized and compassionate high-quality care to patients with sleep apnea, snoring, and related ear, nose, and throat disorders. So with that, I'll turn it over to Dr. Kaffenberger.
Thanks, Craig. Very kind introduction as well, and I'm certainly pleased to be here with you all. And certainly, first and foremost, want to thank the Eye and Ear Foundation not only for supporting this, but also supporting the department's mission in terms of improving the lives of our patients. So as Craig had already mentioned, the title of this talk is really focused on obstructive sleep apnea treatments. And there's been a number of developments just in the past year that really, I think, altering the field as well. To give you a little bit more background about myself, so I went to med school in Pittsburgh. I went to residency here. I went to a sleep medicine, sleep surgery fellowship at Thomas Jefferson, and then was fortunate enough to come back. I wear two hats. I have boarded in otolaryngology, but I'm also boarded in sleep medicine. And so I try to walk this line and the balance between the sleep medicine and the sleep surgery side of it. And I hope you see a little bit of that balance too when we're talking about some of these sleep apnea treatments here. I do have some disclosures that will be discussed or relevant to the talk here as well, with two of the hypoglossal nerve stimulator companies, as well as a Cryosa Medical, which is part of a clinical trial that I'll at least be mentioning here as well. What I'm hoping people take away from this is at least understanding some of the, from at least a broad standpoint, some of the overview of sleep apnea treatments, and to look at what we actually have in terms of options for our present toolbox. Look at some of the things that are coming down the pipeline, and also what is exciting for us as clinicians and caring for patients here as well. So some context, sleep apnea is an incredibly prevalent disorder as well. And some of the more recent epidemiological studies has estimated at least approximately 1 billion patients across the world have at least some form of sleep apnea. And if you look at just within the United States as well, there's about 54 million. Some more context for that, if you want to compare that to other types of otolaryngologic pathologies within. So new diagnosis from head and neck cancer was about 71,000 last year. Hearing loss in the United States has been estimated to be about 30 million. And as I mentioned, sleep apnea is actually about 54 million. And I put an asterisk on this as well because this is actually differentiating between those with sleep apnea and those who aren't sleep apnea patients but do snore. And so there's a tremendous amount of patients here that aren't even included within the statistic. Suffice to say, sleep is an incredibly prevalent and necessary thing for us as humans. And it is quite often that we run into problems in terms of respiratory or sleep disturbances. So those are all statistics, but what is actually, are we actually treating on this as well? So this is an example of a patient who's in the sleep lab. What you're going to notice is that you're just hearing some breathing, and you're going to hear a pause here. Now I want you to watch the chest, and I want you to also watch the belly here as well. And so as he's trying to breathe right now, because you don't actually hear any air movement, and if you actually had some of the sensors data, you would actually see just flat lines here, except for the respiratory effort belts here as well. You see the sucking in of the chest, this big distended abdomen as well. He is trying to work to breathe right now. And what we've just witnessed is kind of like the steady escalation in terms of effort to breathe here as well. So he's overcome now essentially a clog or a resistance in terms of the upper airway, established a breathing pattern again, but already he's back into an apneic event. He's actually not being able to breathe here as well. And again, you're going to see this kind of slow crescendo up as essentially what's happening in his bloodstream is the oxygen levels are starting to drop. His brain is recognizing that, and the brain is basically telling the rest of the body, hey, you need to breathe. And how is it doing that? Well, it's trying to breathe in its clogged pipe. That's not actually working. So what's now happening is that actually some of these signals are reaching the levels of the brain, and you're actually having what's called an arousal. And when these arousals happen, what it typically does is it kicks you out of some of the sleep, and there it goes. And it reestablishes the airway, gets you breathing again. But the actual act of doing that actually takes quite a toll, right? And so it is a pretty pretty anxiety provoking just watching this patient. Actually, this is someone with pretty significant and severe sleep apnea as well. And you can even just tell like the fight or flight response is really kicking in every single time one of these arousals is happening. And this is kind of a schematic breakdown of what we're actually seeing from a pathophysiology standpoint. Every time we have a clog in the pipe, so to speak, in this upper airway, you're having this increased respiratory effort that you see in the chest and the abdomen that leads ultimately to an arousal, the brain recognizing essentially it can't breathe. It's quite good at recognizing this and then giving you enough of a little bit of a nudge to essentially reopen the airway, breathe down, breathe out the carbon dioxide and breathe back in the oxygen, lets you fall back asleep, and then goes right back into the cycle again. Oftentimes, patients aren't necessarily aware of this. They're not recognizing this as well because our brain sims are quite good at just working on autopilot to correct this as well. But certainly bed partners can notice this, family members can notice this, friends can notice this when people are asleep as well. And the actual act of this, night in, night out, minutes to hours, hours to days, essentially going on for years, this impacts essentially our sleep quality. It fragments our sleep. It causes this fight or flight response as well in terms of triggering these arousals. And there's also some toll in terms of the lack of oxygen or the repetitive damage, essentially what we call hypoxic burden, the lack of oxygen to our essentially entire bodies. How this actually impacts us though in the symptomatology as well as some of the long-term risks for it as well. So certainly quality of life aspects, the quality of sleep aspects, but certainly impacting essentially the restorative effects of sleep. We essentially are more likely to have sleepy during the day, decreased productivity, and anyone with lack of sleep can certainly attest to irritability and certainly worsening in terms of our overall mental health. Morbidity really comes from two main sources, from a cardiovascular standpoint, as well as automobile accidents related to the sleepiness, as you might imagine. But there's a whole host of other downstream impacts, whether that's from an endocrine standpoint, a renal standpoint, in addition to cardiovascular risks as well. Now, sleep apnea has certainly gotten, I think, a lot more press in years past than it did maybe 10 or 20 years ago. Part of that is certainly we have newer options as well. But if you think about it from a historical standpoint, the two big treatment options for patients historically has been one, either CPAP, or two, either UPPP, as it was called, which is essentially a surgery where portion of the throat is cut out. We have certainly made advances since that time, and to a certain extent, those silos really have started to merge in a much more fluid way and a dynamic way across the entire sleep medicine field. So if you go from two, essentially CPAP and pharyngeal surgeries as well, you can see there's a lot more options in our toolbox these days. Nasal surgery and skeletal surgery have been a common option for sleep surgeons historically, and these can certainly be quite good adjuncts, such as nasal surgery, in terms of improving some of the other treatment options we have. And then also skeletal surgery, certainly more invasive than most of these options, but also has some of the strongest evidence in terms of long-term effectiveness. Those have been around a decent while. We've had experience with those as well. But what's more, I think, relevant these days and more often that we're using are things like these oral appliances and obviously nerve stimulation here as well. And I should take at least a brief segue and just mention how Pittsburgh has been involved in, I think, in leading some of these advances and building this present toolbox. Rob Rogers is one of the sleep dentists who recently retired, but he was one of the founders of the American Academy of Dental Sleep Medicine too. And he has really built this sleep dentistry field up from the ground, from basically nothing in the 1990s to a huge thriving industry that is also quite effective at treating patients as well. Pittsburgh is also home to Respironics, which was bought out by Philips. This is one of the biggest PAP machine manufacturers and sleep technologists out there. And also when you look at hypoglossal nerve stim, UPMC and Pittsburgh has been intimately involved in implementation, the clinical trials when it comes to nerve stimulation, largely thanks to Jonas Johnson and Ryan Seuss here, my senior partner, and Dr. Johnson is obviously the former chair here. But from the eye and ear standpoint, what may not be quite as obvious to the audience is how strong we have, how strong our sleep medicine colleagues here in Pittsburgh are as well. Pittsburgh's home to the Center for Sleep and Circadian Science, which is led by Dan Bicey here, who is one of the foremost opinion leaders when it comes to insomnia work. Sanjay Patel is the leader of the cardiovascular risk Institute from the sleep medicine side of it. And then Pat Strollo, who's chief of staff at the VA, former president of the American Academy of Sleep Medicine, one of the big implementers of CPAP alternative therapies as well, and Ryan and I's key mentor, I think, when it comes to the sleep medicine side of it as well. And so Pittsburgh is one of the leaders here as well, and it is honestly a wonderful group to work with and a very collegial group. And so there's been some more recent additions, as I kind of mentioned in the intro, just in the past year, specifically when it comes to nerve stim and this weight loss. And so we're going to first start with nerve stim and actually transition over to the weight loss shortly thereafter. But to give people at least a little bit of background and again, a little bit of context as well. So nerve stimulation targets from a sleep apnea perspective have been theorized for going on 30 years now. And just in the past 10 years really have taken off from a clinical implementation standpoint as well. But this is the one that is most common as well and has been the longest running or the most approved by the FDA for the longest amount of time. It's the Inspire device. And this is a hypoglossal nerve stimulator. Hypoglossal is the nerve that controls the tongue. And you can see a cuffed electrode seen here. It's actually inserted on typically the right side, where the rest of the wires then tunnel down to the battery that lays in the chest. And then there's another wire that actually goes in between the ribs to actually sense the breathing in and breathing out of the patient. The way I phrase it to patients, this is essentially like a pacemaker for the tongue. It senses when you breathe, and what it's trying to do is essentially push the tongue forward as someone breathes in. Patients are able to control this with a remote control that also allows them to modify or adjust the therapy as they need. I had already kind of mentioned this as well, but Ryan and Pat were really the two leaders on this clinical trial as well. And this is really the one that got FDA approval and is, I think, one of the most game-changing aspects when it comes to sleep apnea care. It's been a very busy past 11 years since they did get approval. UPMC was the first center to do these implants commercially as well, outside of a clinical trial. And there's been a lot of advances and a lot of growth since that time as well. For instance, they used to do this as a 3-incision technique. Now it's just 2 incisions. And more recently, we've gone from 2 wires down to 1 wire with this newer Inspire 5. But you can also see there's certainly been exponential growth here just in the past 5 years. At this point, there are over 100,000 implanted patients. They've also expanded this out. It's previously been approved in Europe as well as the US, but now it's also in Asia, Japan, Singapore, and slated, or at least sounds like going to be rolled out in a couple other countries in Asia as well here in the next couple of years. To give you some idea, and I think it's important to talk about exactly how the Inspire works as well. It is a one-sided, a unilateral hypoglossal nerve stimulator that is selective. And when I say selective, that means when we place this electrode, we're placing this very intentionally on part of the nerve. And what we're trying to avoid is actually part of the nerve that supplies these retractor muscles. These are the muscles that pull the tongue back. We're preferentially trying to find or stimulate the nerves, part of the nerve that pushes the tongue forward through these 2 main protrusor muscles, as they're called, the genioglossus and geniohyoid. Thankfully, intraoperatively, this anatomy is pretty well preserved to where we can actually divide or essentially separate out those nerve fibers that are protrusor fibers versus retrusor fibers here as well. And we do this through a number of ways. One of those ways is by doing intraoperative neuro monitoring, where we essentially have EMG, muscle monitors in the tongue that tell us what portions of the tongue is being stimulated. And you can see here in this top left diagram that monitor going off, and you'll see these are the protrusor pushing the tongue forward channels, and these are the retrusor channels here as well. And we're stimming this most superior portion of the nerve. You're seeing that protrusors there. Once we have that portion of the nerve identified, we're placing a cuff around the fibers that are pushing the tongue forward, just like you're seeing here in the top right. And then what you're testing for in the surgery is actually wanting to make sure that the tongue is pushing cleanly, nice and forward, just like that. What actually happens to the airway at night? This is just an example of trying to orient you. A camera that is stuck in the very back of someone's nose, and they're in a drug-induced sleep. And what they're doing is they're actually testing out the stimulation and coming off now. And what you're going to see here is this base of tongue being driven forward. This is the uvula that we're seeing, and this is the voice box. But you can see this nice opening of the airway with that stimulation. I mentioned already, we've kind of gone to a new model with this Inspire, so it's called the Inspire 5. And what's different about it is, instead of these 2 wires, the respiratory sensing lead and the stimulation lead, we just have 1 wire now. So this sensing lead has gone away, and instead there's now a chip in the battery pack that actually senses when patients are breathing in and breathing out. Functionally, that allows for some more advanced programming that we're able to do, and it also allows for a shorter surgical time. We were actually the first center in the country to actually implant these Inspire 5s. We did this, this is the case with Ryan, myself, as well as our fellow Jim Hahn. This was back in last December, and at least at UPMC, the vast majority of our cases now are Inspire 5. The VA right now, we should be transitioning it over here in the next couple of months. And this is just a picture from us afterwards. But it's certainly been a very nice adjunct and a much shorter surgery as well. What else is new? So there's a lot of other companies in this space, and when it comes to hypoglossal nerve stimulator, I mentioned that this Inspire device is really a unilateral, meaning one-sided. So what happens actually if you stimulate both? And so this is the latest company that has gotten hypoglossal nerve stimulator system approved by the FDA. This is just in the past 2 months. This is a company called Nyxoah. What you'll notice differently about this is instead of a cuff electrode, they have paddle electrodes that go onto the distal portions of the hypoglossal nerve. And it is just implanted through 1 incision. So that incision just goes right here underneath the patient's chin, where this paddle system then is deployed. There's a couple other notable differences about this system as well. There's no sensing lead. It is basically programmed to kind of turn on and what they call a duty cycle, meaning that every couple seconds, the device will turn on and then it will turn off to give the tongue a pause and a break. What you'll also notice is that there's no battery pack, at least implanted on the inside. So what this requires then is that patients actually have to wear a little patch, a little adhesive patch that actually has a battery pack that basically stimulates the device through the skin and the soft tissue of the chin. It is also MRI compatible. The Inspire device is also MRI compatible, or at least conditionally so. And so there are some exceptions to that. If you look at the trial that gained the FDA approval, it's called the DREAM trial, and it was set up to kind of mimic what Inspire did with their STAR trial. And in general, you see some pretty comparable results in terms of effectiveness or efficacy, but there's still some lingering questions, safety as well as adherence, and also the patient's ability to adjust for control of the therapy as well. I think ultimately what I would tell patients is we certainly don't have as much experience with this newer system compared to 11 years with the Inspire. But there are certainly, I think, benefits and pros and cons to each of this system. And I imagine there are going to be certainly patients who are more interested in pursuing something like the Nyxoah here in the future as well. That is, at least, we'll talk a little bit more about what's coming down the pipeline with neurostimulation a little bit later. But I think the other really big thing that I think is here and already is talking about weight loss medicines. And so I'm guessing this audience probably already has at least some exposure, or at least has recognized that even just in the past couple of years, there's been some pretty seismic changes when it comes to weight loss medicine, diabetes medicines. And it's really through these glucagon-like peptide-1 drugs. And it's pretty amazing when you look back at the history of it. I mean, just in the past 40 years, they've gone from just identifying what this molecule does to, from a mechanism standpoint, to actually seeing what it does clinically, to actually testing it on certain conditions, and then also seeing the dramatic changes and benefits as well. So essentially, these GLP-1s, it is a small molecule that basically causes insulin release. And so it shifts us from a fasting to a fed state. One of the downsides to this molecule was that when we make this normally, it is actually pretty quickly broken down by our body. And so a lot of these drug manufacturers have basically come up with these small molecule agonists that basically take the place, but also provide a lasting stimulation to the system. And ultimately, what you see is a decrease in calorie intake, increase in cardiovascular benefits, and there does seem to be some neurologic benefits as well. I'm hearing all kinds of at least anecdotal evidence when it comes to things like addiction and using these drugs to also treat that as well. If you look at some of the side effects related to it, and one of the biggest things that has really become a prime indication really is weight loss as well. And this is a graph that shows percent weight change for patients as well. You see diet and lifestyle, followed by all kinds of these medical therapies as well, followed by bariatric surgery over here as well. But the effect of it is pretty profound, I would argue. And the one that really is important from a sleep apnea standpoint, at least from a clinical trial standpoint, is really this medicine called tirzepatide. This was a trial released just at the end of last year in the New England Journal that tested GLP-1 or tirzepatide for sleep apnea and patients with obesity. These patients were essentially randomized to a placebo or to the medicine, where they basically were then treated once weekly with an injection form of tirzepatide, and then all patients underwent diet and exercise as well. What you're going to see here as well in the orange line graph here is that this is the group with who underwent tirzepatide, and you see about 50% reduction over a year in their OSA severity. You compare that to the actual weight loss they experienced here as well. The tirzepatide group had approximately, on average, about a 20% weight change or weight loss over the course of that year as well. This is a pretty profound, I think, impact. There's no question about it. And if you look at the other markers of OSA severity as well. It tends to also treat those pretty well too. But there are some caveats to this, I think, that we have to be kind of mindful of as well. One of those kind of caveats is if you really dig into the data and you look through some of the data and that was published on it, if you look at the rate of quote unquote cure for sleep apnea, meaning how many patients actually who were treated with tirzepatide, how many of them went on to go on and need no further treatment? The way they measure this is by looking at, okay, how many patients would not meet diagnostic criteria for sleep apnea, having this marker of this measure AHI less than 5, or a patient who has mild sleep apnea without significant sleepiness symptoms as well. So if you look at this across this study, what you'll notice is about 42 to 50% of patients were actually within this, for lack of a better term, cure, or who would go on to need no further treatment for it. And if you compare that even a little bit further, if you just look at compare that to the placebo groups as well, there was about 15 to approximately 15% of the placebo groups who also reached that level of treatment too. So if you compare that, that means about 26 to 35% of patients go on to not need further treatments. So there's still a whole host of patients who will go on to still need some form of treatment for their sleep apnea. The other big thing, of course, is this is a drug that you have to keep taking as well. So this is a different clinical trial. It's called SURMOUNT-4. It's again using tirzepatide, where all patients are then treated with tirzepatide over 36 weeks. And then at 36 weeks, patients are then randomized to essentially placebo or to continue on with the tirzepatide. So the tirzepatide goes on to lose another 5%, and then they are about a 25% reduction in total. But if you look at the placebo group, they do gain weight back. They don't gain it all the way back, so there does seem to be some lasting effect, but they go on to lose approximately about 10% of the body weight. This is probably speaks a little bit to the importance of adherence and also just the ability to stay on medicines as well. And obviously in the United States, we have certainly challenges when it comes to insurance coverage. And there are certainly stories out there of patients who go on to lose a lot of weight and the insurance company says they don't need these types of medicines anymore and they lose coverage for it. Or like in the past year or two, there's certainly been shortages as well. And so there are certainly challenges from an adherence standpoint as well. And this goes to show that, maintenance of these types of therapies are still going to be very much required moving forward as well. And I'd argue one of the biggest questions we have right now is how do we actually use this toolbox as well? There's a lot of these new therapies out there, but how do we expand the toolbox and how do we do this from a thoughtful standpoint? What order do we need to be doing this? And one of the bigger things, especially from our sleep surgery side of things here, is how can we use these as combination therapies as well? And just to give you some peek into what we're thinking or how we're trying to do that, one of the obvious implications or utilities is, can we actually combine some of these options with hypoglossal nerve stimulation? So this is one of Ryan Seuss's brainchilds here as well, where essentially what he's tried to do is take other types of staging technology, such as like the tumor lymph node metastasis staging that we use for oncology. Can we actually implement something like that from a sleep apnea standpoint as well? It gives us a little bit more definition. It gives us a little bit more insight specifically into treatment profiles or treatment types. And then ultimately what it does is then also allows us to think about, okay, what patient type would respond well to what? So it's going to allow us to establish that framework and then test these combination therapies as well. So to give you some examples, so for one of our Inspire patients who has very good usage of the device, but on a sleep study still has some residual sleep apnea, well, what other types of therapy could we actually add to the patient to actually get them into, one, they're using therapy well, two, they have symptom improvement, and three, their apnea is controlled. So these might be patients who tirzepatide would be an excellent option to if they're overweight, in order to actually get them to an excellent or an ultimately favorable outcome. So we're going to transition now, and then the remaining 15 minutes, I'm talking about what else is new, what is coming down the pipeline as well. And there is a lot, okay? You'll notice that there's a couple more things on this chart. We're going to talk about some more nerve stimulation. We're going to talk about cryotherapies. We're also going to talk about some more sleep apnea medicines as well. So I mentioned there's a bunch of other companies in this space as well. So Inspire and Nyxoah now have FDA approval, but there's about 6 other companies who are either starting or wrapping up clinical trials here as well. The one that is closest to FDA approval is probably this LivaNova company and their device called the Aura 6000. To put this in context again, this is a one-sided, a unilateral nerve stimulator. It does not require a respiratory sensor. It is an implanted battery, but the battery is able to be charged through the skin. And then what it does is it basically has electrodes that wrap around the cuff. And so what it can then do is actually stimulate different portions of the nerve. They have actually already reported one clinical trial. It's called the THN3 clinical trial that came out 2 years ago. Excuse me. Similar setup to the STAR trial as well as the DREAM trial, but you'll notice that their primary outcome, which was this AHI response, was not as robust as the Inspire and Nyxoah. So they actually went back. The FDA wanted more data before approving it, so they've gone back and they've already released a press release. Hasn't been published yet, so take this with that caveat. But at least it shows some comparable results to the STAR trial as well as the DREAM trial. Ultimately, I would say this is, I'm guessing, probably going to be approved in the next year or two by the FDA once this is officially published, at least. But that's at least my opinion, or at least my thought process for them. One of the other, I think, really cool things within the neurostimulation world right now is stimulation in a new direction as well. So this is actually pioneering work done by Dave Kent. He's at Vanderbilt University. He's a sleep medicine and sleep surgeon there, but he actually did his residency here with Ryan Seuss as well. So he has a lot of Pittsburgh ties. But the idea behind this is essentially we've been thinking about this very much in two-dimensional fashion, meaning that when we push the tongue out, we're pushing the tongue forward. I'm sorry, we're pushing the tongue back to forward. But what if we actually lengthen the airway? What if we pull down on the tube as well? We know that actually excess weight in the chest, excess weight in the belly actually pushes up on the airway by reducing lung volumes. And what that tends to do, it's almost if you think about a slinky, that if that slinky is under no tension, what ends up typically happening then, of course, is that it's easier to collapse. But you pull down on that slinky, it makes the tube actually much more resistant to collapse. And so what Dave has actually found through some of it self-experimentation is actually found a way to stimulate a nerve called the ansa cervicalis, which actually stimulates some of the muscles of our swallowing. So what it does is actually pulls down on the highway by doing this. And he's actually has some really cool videos and work that actually show this in action as well. And the first one, in the interest of time and speeding this up here as well, is just, again, to orient you. We're in a camera in the very back of someone's nose. We're looking at the uvula and the soft palate here. This is the back of the oropharynx, the posterior pharyngeal wall, and someone's spine is right behind us. You're not going to see it just yet, but just below this level, you're going to actually see the tongue and the airway here as well. Once we actually bring the camera a little bit further down, but what we're seeing is the tongue is actually being stimulated right now. I know this because he has it labeled. And now you can actually see tongue right here being kicked on, turned on, being pushed out. Now, what we're actually going to see is that hypoglossal nerve stimulation, the tongue being pushed out, but also combined with this ansa cervicalis. So what you're seeing is we're still parked in the nasal pharynx here, looking down at the uvula, but we're actually able to see is you're able to see all the way down. What's actually happening is, the airway itself is stiffening, it's being pushed forward, and it's also being pulled down on. What that then does is actually provides a much more stable airway and prevents the repetitive collapse and the upper airway obstruction that we see during sleep apnea. This is amazing work that he's done and really pioneered. There's several companies that are trying to take this actually to market to the next step. And so it's going to be very exciting, at least from this neurostimulation world, to see actually what happens with this. To switch gears a little bit, we're going to talk a little about cool sculpting. And so some people may be aware or familiar with this just from an aesthetic standpoint too. There's a lot of interest in cool sculpting to essentially shrink fat. And so there's good evidence that actually if you expose fat cells to cold, that actually those fat cells end up shrinking with time. And so this has been around the aesthetics world for a number of years. But there's a company now that is actually taking that and applying it to the upper airway. So we know that the upper airway actually holds a lot of fat, and the tongue in particular can certainly hold a lot of fat as well. And you can actually detect and determine the amount of fat in this by fat in the upper airway by doing MRI studies. And this is work from Rick Schwab at University of Pennsylvania that has looked at this both pre-bariatric surgery and post-bariatric surgery, where you can certainly see minimization or shrinking down of these fat cells making up the tongue. Now, you might obviously ask the question, okay, what is actually happening then with some of these weight loss medicines when it comes to the upper airway fat? I went to a conference recently and hoping to learn that same question, but they were not, the research is ongoing. They haven't actually released those results yet as well. But I'd be very curious to see what's happening with tirzepatide and fat in the upper airway as well. Regardless, this company Cryosa has actually taken this to a clinical trial test this. This is a single treatment that's done in the operating room to essentially take a probe, place it on the very back of someone's tongue while they're asleep, and then actually deliver a cold therapy treatment to the upper airway. UPMC is actually one of those 6 sites. These are some of the inclusion and exclusion criteria, and we're hoping we'll be up and running in terms of trying to enroll patients by the end of this year as well. So some of the benefits of this compared to something like tirzepatide. So it's a single treatment. It is targeted just for the upper airway for patients. And so the hope would obviously be that you don't necessarily need to maintain weight loss types of medicines in the long run as well. To that point, there is a big shift right now from the drug companies looking at modifying our GLP-1 treatments from injectables to oral medicines here as well. And so this was just published a couple months ago in the New England Journal, where they actually used one of these oral pill-based GLP-1 therapies to treat early type 2 diabetes as well. And they showed impressive results. And so I would very much anticipate that the sleep apnea world is going to be also having some of these oral GLP-1 medicines in the not too distant future as well. But the idea of having a pill for sleep apnea has been around for a long time, not just related to weight loss. This is something else that is coming down the pipeline as well. And so we do know that the hypoglossal nerve itself is controlled very differently when you're awake versus asleep, and also based off what stage of sleep you're in. So there are different neurotransmitters inside the actual hypoglossal nerve system that actually can modify this. And what people have actually started doing is actually trying to target those specifically. And what they've actually shown and what they've actually done is taken 2 old drugs. Atomoxetine is actually stimulant medicine used for ADHD treatment. Oxybutynin is an old anticholinergic used for overactive bladder. And they've actually combined smaller doses of this, given this to patients at night as a way of actually treating their sleep apnea. So this is actually a phase 2 trial called the Mariposa study. You see the placebo-controlled group did not have a significant or really any impactful difference in terms of their sleep apnea severity. But then you compare that actually to the group that actually did have this combination of treatment, and there was some reduction as well, approximately about 50%. This is a phase 2 study, and so the company then has gone on and actually just released a press release for their phase 3. And they had 2 phase 3s, and actually both of these were led by Sanjay Patel and Pat Strollo at Pittsburgh here again. But the Synergy and the Lunaro trials, what they're called, at least in the press release again, what they show is about a 20% resolution of their sleep apnea, but at least a 50% reduction in severity and approximately a 50% change in their apnea severity, apnea-hypopnea index. And then if you look at, this is from Pat's the quote from it. So these are, I think, coming down the road for us as well. I would suspect probably in the next year, maybe 2 years as well, that these are going to be options for patients as well. So This OSA toolbox continues to expand. There's going to be a ton of things coming out, and there's going to be a ton of work in trying to implement this in a thoughtful manner and also a very personalized manner for patients as well. I haven't even touched on some of the newer aspects when it comes to CPAP as well as pharyngeal surgery. Each of those in and of itself has a whole host of new things going on with it as well that are also extremely exciting. If you are interested, I'm giving a talk on pharyngeal surgery tomorrow, actually. If you would like to hear that as well, please let me know because then I can send you a link. Then I would also tell you that there's a lot of work trying to make CPAP more comfortable as well. So there's this new model or at least algorithm treatment coming out called Kairos, positive airway pressure as well. That also has some improved adherence data that they are reporting, but that is potentially going to market in the next year as well. So I hope things that you can take away from this is obviously that this treatment field is rapidly evolving. The other thing I would say is I think our sleep division here within the Department of Otolaryngology is also pretty uniquely positioned to implement these as well as study these. And the reason I say that is, you know, I think we are the only institution in the world that has three sleep ENT trained, dual boarded otolaryngologists as well. And that involves our leader, Ryan Seuss, our partner, Rachel Whalen, as well as myself. And then we also have three sleep focused PAs here as well, Jared Yon, Emily Copeland, and also Tarek Siala as well. And so I think we are really uniquely positioned to be, you know, leaders at the forefront of this new world of sleep apnea care. And it's an extremely exciting time for us. You know, I've thought a lot about how ultimately kind of algorithms that we're going to have. And I think those algorithms are very much in their infancy in terms of kind of the flow through. But at least in building off the current clinical practice, I still foresee certainly a strong role for CPAP for our patients. I very much foresee us still being tightly involved in troubleshooting for patients, but also being very involved in assessing alternative therapies, whether that's stuff like oral appliances, as well as surgical alternatives. But I think we also have to keep in mind that weight is important. It's not the entire story with sleep apnea, but the weight has to be, I think, factored in. And honestly, I think that can be implemented at pretty much any phase of this algorithm. And then also with these newer medicines coming out as well, there are more pharmacotherapies too, especially once we get into some of these alternative therapies, therapy options as well. So I would end on this, you know, I would say the sleep apnea or even really sleep medicine field itself is one of the youngest when it comes to you know, medical care. Sleep apnea is really first described as a pathologic entity in the 1970s, and so I think in many ways we're still very early on in terms of our experimentation and also learning how best to treat patients as well. But with that, I'm certainly happy to take questions that anyone might have here.
Thank you, Dr. Kaffenberger, for a great and very informative presentation. And with that, we have a lot of questions, so I'm going to kind of dive right in. The first question, actually, one of the first things we see is a couple people are asking for that link for your presentation that you're giving on the 25th. So if you could share that with us, Dr. Kaffenberger, and then we will send it out from the foundation to everybody that's attending today so they have the option to attend that.
Lovely. Happy to.
And then the first question we have is, how often do you need a sleep study for sleep apnea diagnosis?
Yeah, it's actually a great question. At least for the time being, pretty much to get a diagnosis of sleep apnea, you have to have a sleep study. Historically, that probably hasn't always been the case, but for all intents and purposes these days, in order to get a diagnosis of sleep apnea, you have to have a sleep study. That can be done at home. The vast majority of our patients do home sleep studies, and they have come a long ways in terms of ease of use. But it can also be done as the in-laboratory sleep study, which is kind of the, you know, typical what you would expect, what that initial video showed of someone sleeping in the sleep lab, essentially staying in one of the, like, an overnight hotel with a bunch of monitors.
How accurate is the new Apple Watch program at detecting sleep apnea?
Yeah, so really good question. There was a really good podcast actually on this as well. It's a podcast called Talking Sleep, where it's actually through the American Academy of Sleep Medicine, where they interviewed one of the leaders in terms of the watch's implementation and accuracy. And when you listen to it, I'm blanking on the guy's name. But what they talk about is that when they actually designed the algorithm for the Apple Watch, um, it is really good at ruling in sleep apnea, but it doesn't necessarily rule out sleep apnea. So I guess that when they designed that algorithm, what they really wanted to make sure is that if someone actually has an alert coming from their Apple Watch, that they really want to make sure that it was tried and true, or like someone with really, really high likelihood of having sleep apnea. But just because you're not getting sleep apnea uh, uh, warning or alert on the Apple Watch, just I would say certainly doesn't mean you have sleep apnea. Okay. And then the other thing would be, how accurate is as a treatment surveillance device, right? Meaning how good is it at actually monitoring therapy success? We don't know. I've yet to see any data on it. It's funny, I actually emailed the that guy from Apple as well, asking that question when that podcast came out.
Is the tongue stimulation with Inspire continuous or only when an event occurs?
Yeah, great question. So um, it is continuous, but it's not completely on all the time. So to make it a little bit more for a little clarity on it. So what it is doing is it is basically timing your breathing cycle with the stimulation. And so as you breathe in, what it's trying to do is push the tongue out. And as you're breathing out, it basically is trying to relax. So if you continuously stimulate the nerve, what ends up happening is you get fatigue of the muscle fibers. And so what you need to do is you need to have a built-in pause with every stimulation in order to keep the tongue um, without having pain or without feeling like it got a huge, tremendous workout in the morning as well. We still have some patients who do describe kind of some discomfort related to that kind of tongue soreness as well. But the idea is it's trying to run in the background of your sleep and trying not to disrupt your sleep. But it doesn't actually know when you are having an event versus when you're not. And that's the same for Nyxoah, that's the same for LevoNova, all of those therapies.
I think this question's along the same lines as the Apple Watch, but I actually don't know what this product is. But is the Aura Ring great for tracking sleep apnea patterns?
Yeah. So the Aura Ring is another sleep tracker. Um, I would say so. The reality with wearables right now is there's a lot of data that comes from them, but not always I'm not always super confident in terms of trusting them. Um, what I do find valuable is probably tracking patterns over time. And so one of my sleep surgery colleagues has actually looked at that with Inspire patients as well. And they basically gave 6 patients Oura rings and were basically tracking them as they actually underwent treatment for it. Um, I've even talked to the Oura Ring company as well about trying to actually implement this in a little bit bigger way and testing these therapies out for exactly, sleep apnea longitudinal management as well. But one of the downsides is they don't have as great of an oxygen sensor as something like a sleep study would. The amount of times that there are actually detecting your oxygen level is nowhere near as frequently as a true sleep study or a pulse oximeter at night. And that goes also with the Apple Watch, right? I think in order for them to maintain battery life, I don't think they have as frequent of measurements on it. I think that's one of the downsides. What I would tell you is I think they can be informative, but not, I think you should be very cognizant of the context of of the devices themselves. And I would tell you also that there have been some people in the past couple of years who have used like, if you look at American Academy of Sleep Medicine, there's someone who has, she essentially used 6 different wearables at the same time, and then also tracked a sleep diary. And she woke up in the middle of the night and read like a book or something for like 3 hours. So low intensity, not really doing much. And I think 1 out of the wearables was actually able to detect that. So there are certainly some accuracy issues that are still going to be worked out, but I don't think it's a huge bet to say that, I think wearables are going to be a big thing in the future of this field. Sorry, long answer.
No, that's a good answer. Dedication by that woman who did that.
Yeah, seriously, right?
Is there any relationship between sleep apnea and mouth breathing during sleep?
Yeah, it's a really good question. So, nasal versus mouth breathing. So, nasal breathing, if you look at normal healthy patients without sleep apnea, nasal breathing is typically the preferred route of breathing. There was studies that showed decreased airway resistance, meaning it's easier to breathe through your nose than your mouth. Um, for a number of reasons. There's a couple mechanisms both inside the nose, as well as just kind of the position, especially of the tongue, when we get mouth opening. We do a lot of these sleep endoscopies where we bring patients to the operating room, we induce a sleep on them, and then we're actually able to manipulate, mouth breathing, nasal breathing, excuse me, mouth opening. And oftentimes what you'll see for a lot of patients too is as the jaw drops, the tongue often falls back as well. So it's mouth breathing is quite a tricky one to actually treat as well. There's not a lot of evidence that some people can convert people from mouth breathing to nasal breathing, especially as a bit habitual over years and years and years. But we certainly do make at least an effort in terms of trying this as well. Um, I have a pretty low threshold for trying patients on mouth tape, or chin strap, or we've even had some patients get like a C collar as well to essentially prop up the chin to prevent it as well. I think there is something to it. I think there's probably a little bit of a fad aspect when it comes to the mouth taping as necessarily a cure-all, but I think there is probably something to us breathing through our nose rather than breathing through our mouth.
Like many people, I've never been able to adjust to a CPAP machine. I have a full face mask. Could you provide more info on what a KPAP will do?
Yeah, so Kairos PAP is Kairos is Greek for time, and essentially, I'm certainly not an expert in this as well, but there's another Talking Sleep, American Academy of Sleep Medicine on this as well, where they talk to the inventor of it as well. But the idea is that essentially CPAP is giving you a fixed pressure over your breathing cycle, meaning as you breathe in, it's giving you the same amount of pressure as you're breathing out against it. A BiPAP is essentially where they give you, as you breathe in, it gives you an increased amount of pressure. And then as you breathe out, it gives you still a little bit of resistance as well. So an inspiratory positive airway pressure versus an expiratory positive airway pressure. When it comes actually to sleep apnea, they think actually the expiratory positive airway pressure is probably the most important thing. It's the stent, it's the amount of baseline kind of air that's going into the airway to essentially prop it, or almost act like a balloon, blowing air in a balloon to keep the airway open. So what Kairos is supposed to do is, as you breathe in, it actually is supposed to drop the pressure, and as you breathe out, it's supposed to give you a little bit more pressure. So it's kind of like an inverse of the BiPAP. I haven't tried it myself. I'm not entirely sure, but they do say that it's supposed to actually make some difference when it comes to patient adherence when they've been testing it out. I would also say that building off the prior question when it comes to mouth versus nasal breathing, even in folks who are mouth breathers, at least in our practice, we are still pretty aggressive about trying patients on nasal masks. There's some evidence that actually nasal masks, when it comes to CPAPs, tend to actually have about a 1 to 2 centimeter on average decrease amount of pressure. The adherence rates also tend to be better for nasal masks versus full face masks as well. And we've even had patients, who are very much trying on full face masks who have ultimately transitioned over to a nasal mask because actually, I mean, CPAPs actually give you a decent amount of air, right? And so they can actually stent open the nose as well, or at least open up the nasal breathing passages as well. And so we have a pretty low threshold for really transitioning patients from full face to a nasal mask, especially if there's any troubleshooting or difficulties with adherence related to them. And if for patients who, worried about essentially mouth breathing or air leak through the mouth too, like we've absolutely tried mouth tape for those patients with a nasal mask or chin strap. Same type of story. I had that exact story yesterday for one of patients I saw in clinic who tried a full face mask, didn't work, was very miserable, disrupted sleep, and then we transitioned over to a nasal mask with a mouth tape, and she's actually done amazing. That was her yearly follow-up yesterday.
Is supine sleeping position the worst for sleep apnea? And if not, is it the worst one?
Yeah. So there is a subset of patients where that is true. It's probably probably a majority of patients. I think the way I conceptualize it as well is you have the full weight of gravity or the full effect of gravity on the tongue and the soft palate. So those are more likely to probably block off the airway. Not true in everyone, but if you look into some of the positionality data, some of our sleep studies have them, especially the home sleep studies. Some of the home sleep studies do, as well as the in-lab now. But you can actually see differences, sometimes pretty dramatically, like sometimes 2 or 3 times of severity when someone's sleeping on their back versus sleeping on their side. So yes, but not in everyone.
Does the Breathe Right strip help with nasal breathing?
I think it does, yeah. So it's a class of treatments that I would label as external nasal dilators. I mean, all they're basically doing is basically just trying to expand the inflow or essentially expand the amount of space within the nasal airway. I am often recommending, I often have patients try them. The other thing I'll have them try, especially for folks who have, sweaty skin or, these things fall off, they also make these things called internal nasal dilators. And they are literally like these little springs that slide on the inside of the nose, and they do the same thing. Sorry, it looks strange, but what it does is it basically pulls out, pushes out, and so it expands the amount of airflow in the nose as well. So I typically recommend stuff like Mute, M-U-T-E. You can find them on Amazon. There's Airflow as well. There are some athletes out there who are using this type of things as well to try to maximize essentially airflow through the nose. I would say, on this topic of mouth versus nasal breathing, when we look at nasal treatments in general, especially when it comes to sleep apnea, whether that's medical, whether it's surgical, whether it's, dilators, we tend to actually, if you were to test someone's sleep apnea before and after a nasal treatment, tends to actually not make a difference in terms of the actual typical metrics that we use to measure sleep apnea severity, mainly the apnea-hypopnea index, the AHI. What we do see though is that it does make treatments easier to use, and it can improve actually sleep quality. And about 50 to 60% of patients also have improvement in snoring. So it's kind of an adjunct, I think of in a lot of ways. It may actually help us improve some of the sleep quality or tolerance of other therapies, but you can't actually hang your hat on it as a tried and true treatment for underlying sleep apnea.
All right, and that takes us right to our 1 o'clock quitting time. So again, we want to thank you, Dr. Kaffenberger, for a great presentation. And thank you for everybody who joined us today to hear about all these new treatments. We will get that link for Dr. Kaffenberger's upcoming talk out. We'll also be sending you a recording of this webinar. If you have any questions, again, you can email them to myself. My email is craig@eyeandear.org, and we'd be happy to get those answered for you as well. And thanks again. We hope everybody has a great day.